California has been a leader among states in implementing the Affordable Care Act and in establishing its health benefit exchange. The state has far exceeded its goal of enrollment of 1.4 million people in covered California, the state's health insurance exchange, and millions more have signed up for Medi-Cal, the state's Medicare provider. That's not to say there haven't been some glitches along the way. We'll look back at year one of the Affordable Care Act and examine what to expect in year two with Diana Dooley, California's Secretary of Health and Human Services, and Dan Weintraub, editor of the California Health Report, the Affordable Care Act, a first-year examination.
Additional funding for the Maddy Report made possible by a grant from Paramount Agricultural Companies, growing healthy food for you and your family.
From the California Channel at the state capitol, Valley PBS, and the Maddy Institute, it's the Maddy Report with Executive Director of the Maddy Institute, Mark Keppler.
Welcome. When told by the White House point person that California was the nation's pace car on health care reform, our guest, California Secretary of Health and Human Services, Diana Dooley, was reported to have told him that she didn't want California to be the pace car because pace cars don't win the race. Instead, she wanted California to be the lead car. By all accounts, California is the nation's lead car in health care reform, and we're delighted to have Secretary of Health and Human Services, Diana Dooley, back on the Maddy Report.
Great. It's my pleasure. I'm very glad to be here.
Good to see you. Well, so what are the numbers? Did you meet your first year targets?
Well, we actually exceeded them, and while we have had a very successful launch, you're not going to see a mission accomplished banner over our carrier here. This is hard work and there's a lot to do, but we did very well in the first year. We exceeded all of our targets. There were 1.2 million enrolled in the private product sold through the Covered California, and over 2 million enrolled in the Medi-Cal expansion in California. So we embraced it, and the people of California embraced it, and a lot of people are getting health that they've never had before.
You know, one group that you've been particularly successful with were Latinos. You were able to cut the uninsured rate in half, from 35 to 17%. How'd you do it?
Well, we had a very strategic and tactical approach throughout the communities and all of the neighborhoods, working with local organizations, trusted advisors. We had a lot of Spanish language work. Early on in the first open enrollment period was 4 months, 6 months really. And at the end of the first 3 months, there was some concern because the numbers were quite low with the ethnic populations as well as some of what they call the young invincibles. But we found that they made their decisions late. They took in the information.
Gee, that's a surprise. Being a professor, young people making their decisions late.
Right. But by the end, when we closed down in April, we had not only reduced the uninsured among the Latino population by half, but overall in California, the uninsured rate was cut from 22% to 11%.
Amazing statistic. You know, I'm just curious, which do you think played the bigger role? You've got, you know, subsidies on the one hand, kind of the carrot, but you've also got the penalty, kind of the stick on the other hand. Which do you think made a bigger difference?
Well, we spent a lot of time in the planning for this, making that determination, and we didn't use the stick at all. We really believed there was an appetite for the security that comes from having health insurance and knowing that you aren't one illness or injury away from bankruptcy. So we have left the stick aspect to the IRS, and people will have the first year of penalties coming up in 2015 on the 2014 taxable year. So I think there'll be a little more noise around that and people will be more aware of it, but it isn't coming from us. We're trying to be the trusted partner with Californians to meet the triple aim: better health, better care, lower cost.
Great. Well, another issue I want to talk to you about was Medi-Cal. Those numbers were particularly striking. Over 2 million enrollees. How'd you do that?
Well, we inherited from the Schwarzenegger administration a commitment to the Affordable Care Act. They had established the health benefit exchange that's now called Covered California, but they had also entered into a contract with the federal government to expand Medi-Cal ahead of 2014. It was called the Low Income Health Program. And almost all the counties in California participated and began moving their indigent populations, the childless adults that had no system of care into the low-income health program. So all of those, there were almost 700,000 Californians that had started to get care through a coordinated system at the counties. They automatically transferred into the Medi-Cal program on January 1. The rest of the expansion came from the benefit of the promotion of the Covered California product, because we were enrolling people in whatever they were eligible for, whether it was Medi-Cal or an insurance product.
It's when you have that bipartisan cooperation, I guess you can get a lot of things done.
Yes.
So what's the cost of all these new Medi-Cal, people coming into Medi-Cal? What's going to cost California?
Well, the expansion population of Medi-Cal is 100% paid for by the federal government through 2017. And between 2017 and 2020, that share of cost will gradually grow so that by 2020 and beyond, California's share will be 10% of the cost.
So the federal government is still picking up 90% of the cost,
Well, even then, at the end,
right,
they will still pick
now
up
it's
90%. Now it's 100%.
Okay. So are we seeing lower health care costs as a result of this, or at least a deceleration of healthcare costs?
Yes, we have, here and across the country. The numbers have been moderating. We're not turning, we're not having an absolute decrease, but the rate of growth has slowed significantly, both in the underlying cost of care and in the premiums charged through insurance, not only for Covered California purchasers, but in the employer market as well. Some of that comes from the recession. To be fair, there are a lot of procedures that are deferred in a period of economic recession. But as we've come out of the recession, the rate of growth has slowed. And some of that is through coordinated care. A lot of it is from the changed incentives that exist under the Affordable Care Act.
Okay, great. Well, a program so massive is bound to have some glitches in its inaugural year. The question is, are they being taken care of in year two? We'll have that conversation in a moment. This is the Maddy Report. Welcome back. We're discussing California's rollout of the Affordable Care Act with the state's Secretary of Health and Human Services, Dooley. I want to talk about some of the challenges and some of the lessons learned after the first year. I guess the first question would be the first point of contact, getting the counselor on the phone. There have been some reports that the wait times have been up to an hour. Is that true? And if so, what's being done to correct it?
Yes, it was true at the beginning. We were a victim of our own success, and we had far higher call volumes. We spent a lot of time in preparation. We established as a policy what we called the 80-30 rule. We wanted 80% of our calls answered within 30 seconds. We didn't answer our calls within 30 minutes at the beginning. But what we found was the appetite was so large and the need so great that people called back, they waited. We had a lot of reference points to local community assisters with the enrollment process. And so, as I said before, we exceeded all of our numbers, even with those long wait times. As we go into the next open enrollment, which will start in just a few weeks, November 15th, is the second open enrollment period. And we have added over 800 new call center employees through a contract that will be for surge, that will help in those peak periods, in addition to, we have a call center in Fresno, and we have one in Contra Costa and one in Sacramento. And that, coupled with the training, the understanding, the experience that comes in year two, I'm not going to promise that we're going to hit our 80-30 target, but we're going to come a lot closer to it.
It's interesting, though, when you have a numerical target like that, it really focuses, it concentrates the mind.
Yes.
Health insurance premiums, they're increasing 4.2% on average in year two, and some insurance companies are continuing to narrow consumer choice in terms of doctors and hospitals. Is that a problem? And what, if anything, should be done if it is a problem?
Right. Well, the rate of increase in the premium we were very proud of that. In year one, most of the national predictions were that it would be almost impossible to stay below 10%, and we were below 10%. We went well below 10% this year with the 4.2 number. There are a lot of variables in that, but in large part it's because of the active purchaser role that we've made and the opportunity to negotiate directly on behalf of all of these individual buyers of insurance that don't have an employer or a large trade union to negotiate on their behalf. On the issue of the networks. This is really part of the delivery reform of systems of care, and more we're going to see alignment between physician providers, hospital providers, and plans that look a little more like Kaiser, even when they're not a health maintenance organization structure. You're going to have hospital systems aligning with physician systems, and that ultimately is going to help with the coordination problem and the reduction of duplication of service. So while we're thinking of it in terms of narrow network right now, we're going to have closed networks, and I think that at the end of the day, we're going to have better care as a result.
And it's interesting, polls show that that's what people care about really is the cost. They're okay with narrowing as long as you keep the cost down, so it seems like you're going in that direction.
Well, and I think people are understanding that there's a trade-off. You can't have unlimited choice and have affordability. So the affordability is going to cost us something.
Let me ask you about the Medi-Cal explosion, really, of enrollees. Are people having there's good news and bad news there, I guess. Is the bad news that maybe it's harder to find a doctor for Medi-Cal enrollees?
We really haven't found that. We were watching very closely. We have very strict access requirements under the federal terms and conditions of our Medicaid program called Medi-Cal in California, and we have not found that. And in part, I think because of the lead up with the low-income health program in the counties, they were establishing systems of care. So we've got almost 70% of the Medi-Cal population is in managed care now, and so the plans are responsible for competing on the basis of service, and they have to see that patients are seen within a timely time. There's better coordination between primary care and specialty care. LA County, for example, has reduced its references to specialists because the specialists are now working with their partners in primary care delivery. So it is part of the change that is resulting, moving away from fee-for-service and payment on the basis of episodes of care to coordination of care that lead to better health.
Okay. Well, up next, we're going to look at the changes in the Affordable Care Act in year two. That conversation in a moment. This is the Maddy Report. Welcome back. So what can we expect in year two of the Affordable Care Act? We're talking to Dooley, California Secretary of HHS. So what are the goals for year two?
Well, we want to renew the enrollment of the people who enrolled last year and cut further into that uninsured. I think our target this year is about 500,000 new enrollees. Those will be harder. The people who really understood the need got in the first year, so we have a reasonable target for that. But I think beyond the open enrollment this year, we will be really looking at some of the issues around our active purchasing and our relationship with our plans, where we will look at the benefit design, we will look at some of the issues related to people's understanding of the charges, their out-of-pocket costs, their deductible costs, their premium costs. We've been expanding our capacity on quality and performance reporting so that we can marry cost with quality, and so people can make a value judgment. All of that will be coming in year two.
It sounds like year two begins, you begin to tweak the program.
Well, and we also make it operational. I mean, this was a massive undertaking, and we had tremendous response, and so we've struggled a bit to get it all incorporated. We've had some backlogs in our Medi-Cal with getting everybody incorporated into the system. So we've now got to move into a more operational, less of a startup, and make this last.
So working out the kinks after the first year.
Sure.
What are the major changes in year two?
Well, there aren't any changes to the benefit structure. We made very clear in year one that we wanted at least 2 or 3 years of stability so that people could compare year over year. For those plans you mentioned that we had a 4.2 average premium increase, that's the average. There were some plans that got no increase. There were a few plans in Southern California that actually had a premium decrease. That means there were some plans that were 7 or 8% in their premium. So people can stay with the plan and pay the increase, or they can shop. And so we wanted there to be stability and comparability so people were comparing apples and apples. So there won't be any changes to the plan design in year 2.
Okay. California is the only state to see fewer numbers of insurers participating in the exchange in year 2, dropping, not a huge drop from 12 to 10, but why is that? And are there any repercussions for California consumers?
It's really relative. We had more plans in the beginning than most other states. There are many states in the country that have only one plan in the whole state. The size of California, we have a very competitive insurance marketplace. The 2 plans that did not come back in were because of conditions that they faced with compliance with some of the federal rules. They were happy with their experience, we were happy with their experience, and the number of enrollees was under 20,000 in both of them combined. There were plans that wanted to come back in year 2, but it's a little bit like the little red hen. You can't come and eat the bread if you didn't help build it and plant it and tend it. We made very clear at the outset that we wanted some stability for the first 2 or 3 years, both for the comparability of the product, but also so that we have committed partners that are committed to our values and giving consumers a good value. We have 3 or 4, in some cases 6 plan offerings in almost every region of the state. So there's plenty of choice.
Do you see adding down the line, adding insurance companies?
Yes, I think that's possible when we move down the road. But we've got all the major players. There are a couple that have chosen to be in the employer market only. If at some future point they want to move into our market, we'll certainly entertain that.
You know, it's interesting, despite all the information about the Affordable Care Act, there are still people that don't know about it. So what are you doing to reach those people that still may not know about the Affordable Care Act?
Well, most people get their insurance through their employer. So of the 25 million one way or the other of insured Californians, less than 2 million are uninsured. So the market that we have to have know about us is a very small part of the market, so that there are a lot of citizens that don't know about it. It's not going to affect them. They're getting their health care somewhere else. We're being very focused on the opportunities to reach people who actually need the product that we're selling.
Okay, well, I want to thank Secretary of Health and Human Services Dana Dooley for joining us. Up next, a discussion of the ACA from a different viewpoint, someone who reports on health care issues, Dan Weintraub. That conversation in a moment. This is the Maddy Report. Welcome back. So where do we go from here? Our next guest is Dan Weintraub, the editor of the California Health Report. Welcome back to the Maddy Report.
Thanks for having me.
So after a year, what grade would you give California's rollout of the Affordable Care Act, or Obamacare?
It's hard to boil it down that way. If you're going to hold a gun to my head,
Professor, I give grades.
B-. Okay. But it depends on where you sit in connection to Obamacare. If you were a low to moderate income person who could not afford and could not get insurance before, you'd probably give it an A, because now chances are you've got it. If you're higher income and you already had insurance, it's either not affected you or potentially affected you adversely, and that grade might be a bit lower.
Which is the larger population, though?
Probably the folks who did not have insurance and have it now.
So it tilts a little bit maybe more the other way. So that's why I guess you gave it the B-. So these things are big programs, and all programs need improvements somewhere, right? So where do you see improvements that need to be made here to make this a better program?
Well, there's a couple of things, and unfortunately they're contradictory. If you improve one, you might worsen the other. One of them is cost, and the other one is access. So cost, the monthly premiums are affordable, and that's gotten a lot of attention. Unfortunately, the deductibles, the amount that a person has to spend out of pocket before their full coverage kicks in, are pretty pricey, and they can be up to $6,000 for an individual and $12,000 for a family. That's a lot of money, and they're getting some pushback on that from people who are trying to use their insurance. But if you try to lower those costs, you run into another problem, and that is the networks of doctors and hospitals that are part of these plans are much smaller than people are accustomed
But
to.
that's their way of controlling costs, right?
Right.
They're
So-
narrowing those networks.
So you can't do both. You can't lower the costs and expand the networks at the same time. And so people are complaining about both those things, but you can't resolve them both at the same time. You've got to compromise either on the cost or the access, one or the other. But there are people who have this coverage who say, I can't find a doctor in my town who will see me. That's not good.
Well, let me ask you this. Before I want to ask that another question on that, but first you made me think of what about the whole idea of the marketing and the ease of use? You know, people call up
Yeah.
and they get put on hold or something like that. Is
That seems to be going pretty well in California, especially compared to the rest of the country. But I really think that's kind of secondary to the basic questions of whether this product is good enough for people to, get their health care. The waiting times, the computer system, that will eventually take care of itself, or it will be taken care of. But the core question of, is this good insurance or not, that's going to live on.
Well, I think it's interesting. I just went to my doctor. I didn't see my doctor, though. I saw a nurse. And so I think it's considered a minor problem, and so you don't see the doctor anymore. I think that may be a way to perhaps control costs.
But that's probably a good thing, and it probably could have or should have happened with or without the Affordable Care Act.
This is certainly pushing it. Well, let me ask you about this. Recently there was a story about Walmart cutting health insurance benefits for 30,000 part-time workers.
Right.
Are we seeing companies drop health care for their employees?
Well, we have been seeing companies dropping health care for their employees for a long time, even before the Affordable Care Act. But I think there's definitely been a nudge here because the new requirements, some of the companies are saying it's just too much to deal with in the bureaucracy. But there's another interesting issue, and that is a lot of these low-income part-time employees are actually getting better coverage through the ACA than they were getting at work. A lot of them had very bare bones or sort of catastrophic policies, and when they buy it through Covered California, sometimes with a stipend from their employer, they're actually getting a better deal.
Better deal. Okay, well, let me ask you about another group, the uninsured. That's the undocumented. 2.5 million, I think, undocumented in California. What's happening with them?
Well, they are barred by law from accessing this insurance under Covered California, even if they wanted to do so with their own money. There have been proposals in the legislature to sort of create a parallel program because the federal government won't touch it. California could create a parallel insurance exchange to allow these folks to buy into it, perhaps with subsidies. The latest bill died in the Senate. But the supporters are gearing up to push it again in 2015, and there are polls that show that the public is increasingly supportive of that, perhaps because they recognize that everyone in California eventually has a right to health care that might be in an emergency room after they've been denied access everywhere else.
Which is very expensive.
And if they go to an emergency room under those circumstances, we all pay for it. So it sounds like the voters are starting to say, let's fix these problems up front before they get to that point, and it's more humane and would save us money in the long run.
Okay, let me ask you this final question. We've only got a minute left in the segment, and kind of a big question, probably the most important question. That is, in your opinion, is the Affordable Care Act, is it going to ultimately, in the final analysis, improve health care delivery in California?
I'm going to cop out on that because it's really not designed, maybe some people think it's designed to improve health care, but it's really about insurance. And
You've drawn a distinction between the two.
Yeah, it's more about health insurance than health care. And
do you want to talk briefly about the distinction you've made about health insurance and health care?
Sure, or health care and health even. It goes even deeper than that. But keeping us healthy has a lot more to do with where we live, how we live, the conditions that we live under, than it does whether we have access to a doctor or insurance. We all want those things. We all want to be able to go to a doctor. We want it to be covered. I sure do. Right. But ultimately, if you look at the mass population of 38 million Californians and their health condition, that's going to have a lot more to do with how we're living.
Lifestyle choices.
Lifestyle choices and choices that are made for us just by the environment around us.
I think the analogy
than it is health insurance.
The analogy I think I saw you wrote one time was that it's like not changing the oil in your car. You could have the best mechanic in the world, but if you're not changing the oil, you're going to have problems.
You just get the car fixed repeatedly, but ultimately it's going to break down, and the same is true of our bodies. So health insurance, doctors, it's great to have, but it's really 20% of the solution. The other 80 is all these other factors.
So we're going to encourage people to start jogging. Well, I want to thank Dan Weintraub, the editor of the California Health Report, and California Secretary of Health and Human Services, Donna Dooley, for joining us. If you want to stay current on state and local politics, you can sign up for our award-winning e-newsletter, the Maddy Daily. It's also free by logging onto our website at maddyinstitute.org.
And now, another perspective.
The Affordable Care Act has made substantial progress in meeting its goals. Over 15 million people gained insurance, including about 3.9 million Californians. The number of uninsured has dropped precipitously, particularly in those states like California that implemented the Medicaid, Medi-Cal expansions and developed their own health exchanges. Many more have benefited from improvements to private insurance and Medicare. Nationwide, those with new coverage and even those who needed to change their coverage are overwhelmingly satisfied with their new ACA policies. Despite demanding paperwork and often long delays, San Joaquin Valley counties have seen some of the most impressive improvements in coverage. None of the fearful predictions expressed in our region about runaway costs and imploding delivery systems have come true. And nationally, the program has come in under budget and contributed to debt reduction. Yet the 2010 Affordable Care Act remains unpopular with the public and remains embroiled in legal disputes. Some analysts have attributed this opposition to the unrelenting drumbeat of negative campaigns and a continuing belief that there was something illegitimate in the legislative process. Others cite initial difficulties with the operations of the health exchanges, the substantial residual uninsured population, and the experiences for some individuals and employers of increased healthcare costs. From my perspective, continuing discomfort with the ACA in our region mostly reflects two other factors. First, the Affordable Care Act was never intended to change the predominance of the private sector in healthcare and features components intended to increase competition over prices and service quality. Rather than reducing the salience of money in healthcare, providers and patients have become even more aware of how their care options are shaped by cost concerns. Hoping for healthcare experiences shaped by clinical needs and patient preferences, many are disappointed how much healthcare remains a commodity. Second, a key original component of the Affordable Care Act was to expand prevention, reflecting the belief that long-term sustainability of our health system can only be achieved through improvements in population health. Congress dramatically reduced funding for public health activities, and medical care systems have not yet made noticeable new initiatives to promote wellness and disease prevention. So many of us see a new need for investments in health education and support to help individuals engage in health-promoting behaviors. And there's increasing awareness that improving population health also requires new attention to neighborhood quality of life and environmental protection. Unfortunately, these healthy community goals often take a back seat to other priorities in our region. As we enter the second year of implementation of Covered California, there's strong evidence that here and nationally, the Affordable Care Act is meeting its modest goal. Yet continuing discomfort with the law among many in our region offers an opportunity. We can engage a new and more inclusive debate about how to make the healthcare system universal, sustainable, and effective. At the same time, there's an opportunity for broader public engagement around the ways we can improve our region's health by addressing the social and environmental determinants. This is John Capitman for the Maddy Report.
The views expressed in the Maddy Report are those of the individuals participating in the program and do not necessarily reflect those of the Maddy Institute, the California Channel, Casey, or Valley PBS. If you'd like to share your thoughts about the points and opinions shared in the Maddy Report, visit our website at valleypbs.org/Maddy.
This is Mark Keppler for the Maddy Report. Thanks for joining us.